Streptococcal vulvovaginitis is an infection of the outer vagina, vulva, and the vaginal lining, caused mainly by Streptococcus bacteria. Think of it as bad bacteria taking up residence where normally friendly microbes live. The condition was first described in the early 1900s, when doctors noticed groups of women with throat-like streptococcal infections, developing vaginal symptoms after childbirth or surgery. It matters because the infection can cause a lot of itching, discharge, and sometimes spread to the uterus, leading to more serious pelvic problems if missed. The main culprit is Streptococcus pyogenes, group A strep, but other beta hemolytic streptococci, groups B, C, G, can also cause the disease. These bacteria are the same ones that cause strep throat. Risk factors include recent use of broad-spectrum antibiotics, which disturb normal flora, recent sexual activity, poor cleaning habits, for example using scented wipes, a weakened immune system, such as in diabetes or HIV. Streptococci spread from skin, throat, or perineal skin to the vagina during intercourse, after birth, or by using contaminated towels or toys. The bacteria stick to vaginal cells using surface proteins, much like a Velcro hook, allowing them to stay and multiply despite normal cleaning. The body reacts by sending white blood cells and chemicals, like cytokines, which cause redness, swelling, and pain. The classic signs of inflammation. Bacterial enzymes like streptolysins break down tissue, leading to the watery, sometimes blood-tinged discharge, and soreness that patients feel. In the United States, about 2 to 5% of women with vaginal complaints have streptococcal infection. Exact numbers vary because the condition is often underdiagnosed. It most often occurs in women of reproductive age, late teens to early 30s, but can affect any age if risk factors are present. Higher rates are reported in temperate climates, in communities with limited access to health care, suggesting both environmental and socioeconomic influences. Cases rise in late summer and early fall, possibly because warmer, humid weather favors bacterial growth and more social activity. Discharge is usually thin to watery, yellow-white, and may have a faint foul smell, unlike the fishy odor of bacterial vaginosis. Itching is intense, especially around the labia and inner thighs, often prompting patients to scratch, which can worsen irritation. Many women also feel a burning sensation while urinating, because the infection irritates the urethra nearby. Pain during sex is common because inflamed tissue is more sensitive. Patients may start avoiding intimacy. A few patients develop fever, chills, or feel generally unwell, indicating the infection may be spreading beyond the vagina. Doctors ask about recent antibiotics. Doctors ask about sexual partners. Doctors ask about hygiene habits. Doctors look for redness, swelling, and discharge during an exam. A wet mount adding a drop of saline to a microscope slide with vaginal fluid shows many white cells, and sometimes streptococcal chains. Gram stain colors the bacteria. Streptococci appear as round, purple, gram-positive chains, helping confirm the type of bug. Culturing the sample on blood agar lets the lab see the characteristic beta hemolysis, clear zone, that streptococci produce. Rapid antigen tests, like those used for strep throat, can give a result in minutes by detecting streptococcal proteins in the sample. If the lab has PCR machines, they can amplify streptococcal DNA, giving a highly sensitive and specific result, even if few bacteria are present. Doctors must rule out other common causes of vaginal symptoms, such as bacterial vaginosis, yeast infection, trichomoniasis, which need different medicines. Acute infection shows up suddenly, with strong symptoms. Chronic infection may linger, with mild or intermittent complaints. Uncomplicated cases have only streptococcal infection. Complicated ones involve other bugs, repeated episodes, or underlying health issues. First-line treatment is usually oral penicillin, for example amoxicillin, or a macrolide, for example azithromycin, taken for 10 to 14 days to fully clear the bacteria. The typical course is 10 days. Shorter courses risk relapse, while longer courses do not add benefit and may cause side effects. To ease itching and soreness, a cooled sitz bath, topical lidocaine gels, or over-the-counter anti-itch creams can be used. For women with repeated infections, doctors may test for other organisms, advise longer antibiotic courses, or use probiotics to restore normal flora. After finishing treatment, a follow-up visit or repeat culture is advised 1 to 2 weeks later to ensure the infection is gone. Keeping the vulvar area clean and dry. Wiping front to back after toilet use. Avoiding scented products help prevent bacterial overgrowth. Using condoms. Limiting the number of sexual partners. Discussing partner treatment if they have throat strep. Reduce spread. Only take antibiotics when prescribed. Unnecessary use can wipe out good bacteria and let streptococci take over. Only take antibiotics when prescribed. Unnecessary use can wipe out good bacteria and let streptococci take over. Patients should receive clear instructions about the disease, how to avoid it, when to return for care if symptoms return, with proper antibiotics. Most women feel better within 3 to 5 days and are cured fully within 2 weeks. If untreated, the infection can travel upward, causing pelvic inflammatory disease, infertility, or recurrent episodes that are harder to treat. Outcomes are best in women who start treatment early, have no other health problems, and follow hygiene advice. New point-of-care devices can detect streptococcal DNA in minutes from a swab, allowing same-day treatment decisions. Research shows rising resistance to macrolides in some regions, prompting studies of newer drugs like dilaflexacin for vaginal use. Scientists are exploring vaccines that target group of Streptococcus proteins, which could one day prevent not only throat